Hey guys, welcome to the 2010 edition of the DoctorsInTraining.com Step 1 Review course. I'm Dr. Brian Jenkins, the owner and chief educator at DoctorsInTraining.com, and I'll be the physician that's providing these course materials for you this year. This is the 19th time I've taught this course, and we're very excited about this course this year because it's better than it's ever been. This is the highest yield review course you're going to find anywhere on the market, and we are the largest voluntary Step 1 review course in the country at the moment. Before we get started, let me go through a few ground rules with you guys. Number one, your purchase price for this course has paid for one person to view these lectures. So if you're sharing this course with other students, or if you are projecting this course on a large screen, then you're violating federal copyright law, and anybody viewing the course needs to go ahead and purchase the course. Number two, your purchase price of the course has allowed you access to the lecture material for 30 days. So you can view each lecture up to 3 times on the online course over a span of 30 days. Now, it shouldn't take you 30 days to complete the course. It only takes you about 15 days if you go through 3 lectures at a time. But you have the option to view it over 30 days if you like. If you find that you need additional views for a particular lecture, more than 3 views, then you can repurchase a particular lecture a la carte. If you find that you need more access time than just 1 month, then you can extend the length of your course week by week at a prorated cost. The next thing I need to let you guys know is the text for the course is First Aid for the USMLE Step 1 2010 edition. The 2009 edition just won't deal, right? There's a lot of new information in the 2010 edition. There's a lot of errors that have been corrected in the 2010 edition. If you try to use the 2009 edition during the course, you're going to be lost. We refer to the First Aid quite a bit throughout the course. We have found that it's the highest yield review book out there for your Step 1 exam. So we start with that core material and we add a lot of additional information that's very important for you guys to know for this exam. All right, the next thing, how is the course designed? What is the structure of the course? So each day consists of 3 lectures, and each lecture is about an hour and a half to 2 hours in length. I recommend that you take a 10-15 minute break between each lecture like we do during the live course. And since you're watching online, you can watch these lectures in any order that you want. You can skip around if you want, but I would recommend that you do go in order because there is a natural progression of the course. As we go forward in the course, we refer back to information that we learned in the earlier portions of the course. So, the live lectures consist of Monday through Friday lectures, 3 lectures a day. So ideally, that's what I would recommend for you guys. Go through 5 lectures over 1 week, take a couple days to study on your own, take a practice test, and do the next series of 5 lectures. But if you're in a hurry, if you're in a rush, you could conceivably do the entire course over a 2-week period. If you want to take it a little bit slower, since you have a month of access, you could space it out over a month if you choose to do it that way. Each day starts with a review quiz, and each review quiz on each day covers information that we've learned up to that point in the course, so that the Day 6 review quiz covers the information we've learned in the first 5 days of the course. Today, obviously, is Day 1. We haven't covered anything yet, so the Day 1 review quiz covers information that was addressed in the Part 1 emails, so you'll find the answers in First Aid with the questions in the emails. Now, I'm a big proponent of active learning, which I'm sure you guys are well aware, which means I like to quiz you guys. I don't just stand up here and lecture and tell you, that this stuff is, and try to teach you. I want to actively engage you throughout the entire course. So I try to pimp you guys, ask you lots of questions, lots of short answer questions that you're going to find in your review book that we are constantly going to be corresponding to. It is very important that you have your supplemental course materials additionally. So if you have not received those in the mail, go ahead and call our office and get those materials mailed to you as soon as possible so you can really start this course, because it's going to be very difficult for you to complete the course without your supplemental packet that we will mail to you. So the course is really just a tool for you guys, though, okay? How well you perform in your USMLE or COMLEX exam is really up to you. I would recommend that for the last month of your USMLE study that you're studying 10 to 12 hours a day. And about 5 or 6 of those hours will be spent with us, but you're going to need to study 5 or 6 hours on your own. So what does that 5 or 6 hours a day look like of self-study? You guys definitely need to continue to use a practice question bank, like USMLE World or Kaplan QBank. And ideally, you'd go through about 25, 50 questions a day. 25 questions should take you only 30 minutes. 50 questions would take you an hour. For every hour of questions that you go through, for every 50 questions, it's going to take you 2 hours to go through those answers. So for 50 questions, that's 3 hours of your outside study. What else should you be doing? You're going to study on your own for an hour or 2, and I'd also recommend that you study with a study partner for an hour or 2 every day also. So this course makes it very easy for you guys if I can say that, relatively speaking, very easy to study 10 or 12 hours a day during this last push to really reach your peak potential on this test. Now, one other thing I want to say about the question banks is I know some of the question banks, specifically USMLE World, you can take it in tutor mode where you answer the question and the answer pops up right after you answer the question and you get to review that. These 25 to 50 questions a day, I would highly recommend that you do not use the tutor mode, but instead you use the timed mode because you need to get used to having that external time pressure forced upon you so that when you sit down for your actual test, it's no surprise, the time limits are no surprise to you. So don't use the tutor mode, use the timed mode. Now, how successful is this course? Most students find that they're going to increase their practice test scores by about 5% a week. So let's say you're using USMLE World and you're scoring about 55%, which is maybe 55, 60% at this point at the beginning of the course would be about average for most students in USMLE World. If you're going to jump up 5% a week, that 60% starting point will become 75% correct on USMLE World. So 5% a week over 3 weeks means a 15% increase in your overall USMLE scores, what you can expect with our course. Now, some students don't do quite that well, some students do a lot better, but what that translates to in an actual USMLE score is a 20 to 40 point increase in your actual USMLE score. This is huge, guys, which means if you would have scored a 200 or a 215 on your USMLE, we would bump your scores up into the 220s, 230s. All right, so it makes a big difference. And we've seen this again and again, year after year. This is the 19th time I've taught this course, guys, so I really know how to teach this information. I know how to help you reach your peak potential. That's my goal, is to help you guys. All right, like I said, this is a very high-yield course. It is very high-yield because we use surveys of previous students that have taken our course, and those surveys help us determine what is high yield for future courses. So this course is designed from over 7 years of surveys that we've received from medical students, thousands of surveys telling us what was high yield on their tests. Now, we are ethically and morally obligated not to communicate exact information to you that says, look, this question is on the test. But what I do not have a problem with is telling you, look, this is a piece of information that you guys definitely need to know. All right, so how do I communicate that to you? One way is we have a star system. So I'll give something 5 stars, 4 stars, 3 stars, 2 stars, or 1 star. So if I tell you a particular topic is a 5-star topic, what that means is historically our students have had at least 2 or 3 questions on that particular topic. Hugely high yield topic is a 5-star topic, at least 2 or 3 questions. If I tell you something is a 4-star topic, that means historically our students have had at least 1 question on that topic, which is still pretty high yield. A 3-star topic means about 50% of you can expect to have a question on that particular topic. A 2-star topic means it's in the USMLE question bank, and that probably about 20 to 25% of you can expect to have a question. So some of those 2-star topics, it's going to be up to you whether or not you feel like it's important to know that information, whether or not you want to take the risk of learning that, not learning that information. And if I tell you something that's a 1-star topic, that is still fair game for this test, but we have not received any information back on our surveys that have told us that that particular piece of information is high yield. So 1-star topics are fair game, but not high yield to our average, to our knowledge. Okay. So that's pretty much it, guys. If you haven't taken the Day 1 review quiz yet, that's going to be how we start each day. So go ahead and take a few moments, complete the Day 1 review quiz as best as you can. You'll find that review quiz under the review quiz tab of your supplemental course materials. So go ahead and take a few moments to complete that, and then we'll go through those answers together. All right, so let's go ahead and go through the answers to this Day 1 review quiz. Number 1, what primary hormone is increased or decreased in the following diseases? Cushing syndrome, you have elevations of cortisol. Conn syndrome is elevations of aldosterone. Addison's disease is a decrease in both cortisol and aldosterone. What's the other name for Addison's disease? Is primary adrenal insufficiency. With Graves' disease, of course, you have hyperthyroidism, so elevated thyroid. Number 2, what's the function of McConkey's auger? So McConkey's auger, the purpose is to select out gram positives, so you're only growing gram negatives, and to distinguish which the lactose fermenters are versus the non-lactose fermenters. So in order to do this, there's a few key components. There's crystal violet and bile salts. And these 2 substances inhibit the growth of gram positives. So crystal violet and bile salts inhibit gram positive growth. Lactose is the only carbohydrate in this agar, and there's another stain in there called neutral red. So the reason why the neutral red is in there is because if these organisms ferment lactose, they take up the neutral red. So lactose fermenters form pink colonies on McConkey's agar, and non-fermenters are going to be other colors like white. Number 3, what 5 classes of medications are used to treat glaucoma? Very important question that you need to know for step 1. We'll talk about it later today actually, but it's the alpha agonists, the beta blockers, certain diuretics including the carbonic anhydrase inhibitors like acetazolamide, but then also mannitol is another diuretic. So those are 3 categories: alpha agonists, beta blockers, diuretics like acetazolamide or mannitol. Your cholinomimetic drugs, so your cholinergic agonist drugs are used. And there's also prostaglandins, specifically prostaglandin F2 alpha. And we'll talk later today about how you can identify these drugs because they have prost in the name, prost for prostaglandin. Number 4, patient has facial angiofibroma, ash leaf spots of skin depigmentation. So ash leaf spots have this appearance. So this is what ash leaf spots look like. Kind of the reverse of the cafe au lait spots, which are excess pigmentation in the skin. These are ash leaf spots. This patient also has history of seizures, mental retardation. What condition does this patient have? This is a classic scenario for tuberous sclerosis, very high yield. And what neoplasms is this patient at risk for developing? You need to know these. They're cardiac rhabdomyoma, astrocytoma, and angiomyolipoma. Cardiac rhabdomyoma, astrocytoma, and angiomyolipoma. Make sure you know those. Number 5, what is the cause of achalasia and how is it diagnosed? With achalasia, you lose your myenteric or Auerbach's plexus, and because of that, your lower esophageal sphincter is unable to relax. And how you diagnose this is with a barium swallow. So you have the patient swallow some barium, the barium stays in the esophagus, and you see a stricture in the lower esophagus. It's a classic bird's beak appearance. So bird's beak appearance of the esophagus on barium swallow. You can also use what's called manometry, where it's a device that goes into the esophagus and measures the pressure in the esophagus. It's manometry. Number 6, compare the leading causes of death, 15 to 24 to those 25 to 64. So 15 to 24, injuries is number 1. You don't need to know the order, just know, the top 3, top 4, top 5. So injuries, homicide, suicide, and then cancer and heart disease for the age group 15 to 24. Ages 25 to 64, it's cancer and heart disease are the 2 leading killers, and then injuries, suicide, and stroke are the next 3. Number 7, which glomerular disease would you expect to see the following changes? Anti-glomerular basement membrane antibodies on immunofluorescence is Goodpasture syndrome. Kimmel-Still-Wilson lesions on light microscopy is seen with diabetic nephropathy. Spike and dome appearance on EM is membranous glomerulonephritis. Tram track of the subendothelial humps on EM is membranoproliferative glomerulonephritis. Subepithelial humps on EM is acute post-streptococcal glomerulonephritis. Number 8, what are the clinical uses for metronidazole? The mnemonic for this is get gap on the metro. So the get, GET is for Giardia, Entamoeba, and Trichomonas. And then GAP, GAP is for Gardnerella vaginalis, A is for anaerobes, and the P is for H. pylori. So those are important ones to know. Number 9, what are the 2 most common complications after an MI? Number 1 being a cardiac arrhythmia, which is why it's very important to maintain adequate potassium and magnesium levels in MI patients so they have less likelihood of having arrhythmias. So cardiac arrhythmia, and the most common one, or the most severe one, the most lethal one, is ventricular fibrillation, right, after an MI. The other most common complication is left ventricular failure. If you injure a whole bunch of muscle, that muscle is not going to be able to contract. The left ventricle is failing. So you have left ventricular failure, which causes pulmonary edema and can cause right-sided failure. Most common cause of right-sided heart failure is left-sided heart failure, right? What is Dressler syndrome? This is an autoimmune disease that occurs weeks after an MI and results in a fibrinous pericarditis. Fibrinous pericarditis, autoimmune, after an MI. Number 10, what is the cause of chronic granulomatous disease? This is where you have a lack of NADPH oxidase activity. So phagocytes, like neutrophils, they can engulf bacteria, but they can't do anything with it. They can't generate oxygen-free radicals to kill those substances. So basically, you end up with what I call impotent neutrophils, impotent phagocytes. The lysosome basically doesn't work. And what are the consequences of chronic granulomatous disease? You're susceptible to opportunistic infections, of course. You don't have neutrophils, so you're susceptible to Staph aureus, E. coli, Aspergillus. Number 11, what is the WAGR complex? This is a mnemonic, and it's a mnemonic for Wilms tumor, things you can see with a Wilms tumor. What is a Wilms tumor? It's a renal tumor, and it's the most common tumor of early childhood. It's the most common tumor of early childhood, specifically the age range of 2 to 4. So very common. And the other components of the WAGR complex, the W is for Wilms tumor, A is for aniridia. This is an image of aniridia. Basically, it's a congenital lack of an iris. The G is for genitourinary malformation of varying degrees. And the R is for retardation, mental motor retardation. All right, so let's move on to the meat and potatoes of this Step 1 review, starting with subject matter. We're going to start on page 228 today, starting with pharmacokinetics, pharmacodynamics, enzyme kinetics. This is the type of stuff that students don't like to study. You know, it's not necessarily clinically relevant. You know, it's not disease specific. It's not based on diagnosis and treatment. It's, you know, pathophysiology and, you know, very basic science stuff. But this is the type of thing that Step 1 test makers like to test you on. Today is a very high yield day. Everything that we cover today is very important to know, and in a lot of cases more important than disease specific topics. So make sure you know everything, the ins and outs of pharmacodynamics, pharmacokinetics. We're going to go through the high yield points, but don't neglect this stuff, very high yield. So we're going to start on page 228 with enzyme kinetics. Enzyme kinetics, you know, I had one student tell me a couple years ago that you need to know Km and Vmax like the back of your hand. And I've been telling students this for years. It's very important to know about enzyme kinetics for Step 1. They love to test you on it. Probably at least a 4-star topic. I think most everybody can expect at least one question on enzyme kinetics, Km and Vmax. So let's talk about this. So what is Km? Km, like it shows there in your book, in that equation at the top, is Km is equal to the concentration of substrate at 1/2 of Vmax. So Km is a substrate concentration. It's the amount of substrate that's required for the enzyme to achieve 1/2 of the maximum velocity that enzyme can achieve. So Km is a substrate concentration. Now, look in there in the margin. It says Km reflects the affinity of the enzyme for its substrate. Vmax is directly proportional to the enzyme concentration. Decreasing your Km means that enzyme has more affinity for the substrate, and that's important to know. You do not require as much substrate to get to 1/2 Vmax. So a low Km equals more affinity for the substrate, or the enzyme for the substrate. All right, so underneath that graph, you see what's called a Lineweaver-Burk plot. And with a Lineweaver-Burk plot, the slope of the plot is equal to Km over Vmax. And you can see that where this slope intersects the x-axis is 1 over minus Km, and where the slope intersects the y-axis is 1 over Vmax. All right, so definitely be able to recognize where those intersections are and what those intersections mean on this Lineweaver-Burk plot. Like it says there on the right, increasing the y-intercept means you have a lower Vmax because it's inversely relational, inversely proportional. And the further to the right the x-intercept, the greater the Km. So be able to identify those two things. Underneath that, you see another Lineweaver-Burk plot. But here, what we're doing here, we're starting with the uninhibited enzyme. And what happens when you put a competitive inhibitor into the system? That is not changing your y-intercept. It is changing your x-intercept, which means which is changing, your Vmax or your Km. A competitive inhibitor is going to increase your Km. You're going to need more substrate to hit that 1/2 Vmax with a competitive inhibitor. And a non-competitive inhibitor is not going to do anything with Km. You see that the x-intercept has not changed, but the y-intercept is going up. What happens when you're increasing your y-intercept? You're decreasing your Vmax, right? So a non-competitive inhibitor is going to decrease your Vmax. We're going to talk more about competitive inhibitors and non-competitive inhibitors in a few sections from now, but this is an introduction to the topic. You know, an inhibitor is the same thing as an antagonist, right? So these terms can be used interchangeably. A competitive inhibitor is a competitive antagonist, all right? So don't confuse that. And you see just the summary here at the bottom of this section. Competitive inhibitors resemble the substrate, can be overcome by increasing the amount of substrate, so they can be diluted out, so to speak. They bind to the active site. They're competing for the active site. Of the same site that the substrate binds to, that's where competitive inhibitors are binding, which is why they're called competitive inhibitors. Effect on Vmax, again, it's unchanged. Competitive inhibition will increase your Vm, and the effect of increasing your Km is decreasing potency. So a competitive inhibitor will make something less potent. Non-competitive inhibition, just to recap, is going to decrease your Vmax. It's not going to change your Km. It's going to decrease your efficacy. All right, and we'll talk more about efficacy and potency in a little bit. All right, so again, very important, simple stuff. All right, not too complicated to learn, but definitely important, commonly overlooked by students. So make sure you know about enzyme kinetics and the ins and outs of enzyme kinetics. All right, let's turn to your supplemental material, your course supplemental material. Look at page 1 of your handouts under the autonomic section. So autonomic page 1. Go ahead and answer those questions on page 1, the first 2 questions where you're labeling the graphs. And let's just recap what we know here. All right, let's go ahead and go through these answers. So the graph on the upper left, number 1 is Vmax. Number 2 is half of Vmax, which indicates number 3, the concentration of substrate, Km, that's needed to achieve 1/2 of Vmax. Now 4 and 5 you probably didn't get. 4 is indicating a first order velocity. First order velocity, and we'll readdress this in a little bit. But with first order velocity, the velocity of the reaction, or the velocity of the enzymatic reaction, is proportional to the amount of substrate that you're giving here. So number 4 is indicating first order velocity. Number 5 is indicating zero order velocity. Doesn't matter how much more substrate you put into the system, the velocity is not going to change. And that's referred to as zero order velocity. So at saturation kinetics, you have zero order velocity. When your enzyme is not saturated, then you have first order velocity. That's all it's indicating there. Number 6, you need to know what that x-intercept is, and it's one. It's a -1 over Km. -1 over Km, and number 7 is 1 over Vmax. The next 2 graphs on the middle of the page on the left, number 1 is a competitive inhibitor where you're increasing your Km and decreasing your potency. Number 2 is a non-competitive inhibitor where you're decreasing your Vmax, not changing your Km. The amount of substrate needed to achieve 1/2 of Vmax is staying consistent here. So with number 2, the non-competitive inhibition, you're decreasing your Vmax, which is decreasing your efficacy, right? Number 3, on the Lineweaver-Burke plot, is a non-competitive inhibition where you're changing your Vmax. And number 4 is a competitive inhibitor where you are changing your Km. All right, let's move on to the next topic, pharmacokinetics. So pharmacokinetics, also hugely high yields. And I know it's daunting for a lot of you guys. There's lots of equations, and you need to know how to use the equations, and unfortunately, there are some things you need to just memorize here to be able to plug into step 1. But fortunately, there's only 4 equations you need to know regarding pharmacokinetics. Only 4, okay? Not too hard. And here are the 4 equations. The first one is the volume of distribution equals the amount of drug given in IV form divided by the concentration of the drug in plasma. And we say IV form because basically we're factoring out bioavailability here. And when you give a drug IV, it's 100% bioavailable. So the volume of distribution, amount of drug given, divided by the concentration of the drug in plasma. Clearance is equal to 0.7 times the volume of distribution divided by the half-life. There's another way that you can represent clearance, which is the equation is K times the volume of distribution. And so what would you think K is? K is, all that K is 0.7 divided by the half-life. And what is K? K is the elimination constant. So clearance is equal to the elimination constant times the volume of distribution, where the elimination constant is 0.7 divided by the half-life. Easy stuff, guys. The third equation is a loading dose. The loading dose is equal to the concentration at steady state times the volume of distribution. What is the concentration at steady state? What are we talking about here? This is the desired concentration. If you to determine the loading dose, you need to start with what your desired concentration is, and then multiply it times the volume of distribution. The maintenance dose is also the concentration at steady state times the clearance. All right, so it doesn't matter how much volume a patient has, how big a patient has. The maintenance dose is not determined by the volume of distribution. It is determined by the clearance. So in renal disease or hepatic disease, for renally excreted drugs or hepatically secreted drugs, the clearance is going to change, so the maintenance dose will change. But in renal disease, the loading dose will not change, but the maintenance dose will. 4 equations you definitely need to know. Now, there's really no great way for me to teach you guys how to use these equations other than just to sort of throw you to the wolves and give you some examples and see how you do. And then we'll go through the answers. So look at page 2 of your handout, page 2 of your autonomic handout. Go ahead and answer question number 1. There's 5 parts to the question. Answer those, and then we'll go through those together. All right, so let's go ahead and go through these answers. So the first one, what's the half-life of drug X in this patient? Well, the equation for half-life is clearance is equal to 0.7 times the volume of distribution divided by the half-life. You switch it around, you get half-life is equal to 0.7 times the volume of distribution divided by clearance. So you see that in this slide here. But you need to know, in order to come by that answer, you need to know what the volume of distribution is, you need to know what the clearance is. So clearance was given in the question stem. It said the clearance of drug X is 2 liters per hour. The volume of distribution is kind of given. It says it's 0.5 liters per kilogram. All right, but liters per kilogram is not a unit for volume. Right, volume is just liters, not liters per kilogram. So you need to take into account how many kilograms the patient is. So this patient is 60 kilograms. So this patient's volume of distribution is 0.5 times 60, which gives you 30 liters. So the volume of distribution here is 30 liters. You multiply that times your 0.7 divided by your clearance, which is 2, so you get 10.5. So your half-life here is 10.5 hours. The next one, what loading dose could have been used to reach the target concentration of 20? So in order to calculate your loading dose, you take your target concentration of 20, multiply it times your volume of distribution, which we found was 30, and you get 600, so 600 milligrams. And you see the answer here on this slide. C, if a patient begins to show signs of toxicity and the target dose is decreased to 10, so you're going from 20 to 10, what would you do to get to this level? So basically, the target you're cutting the target dose in half, right? Or you're cutting the target dose in half. So how do we get to the new level? Let the patient sit for a half-life. All right, that's the meaning of half-life, and we'll talk a little bit more about half-life in a second. But let the patient sit for a half-life, which is 10.5 hours, and then you're going to have your concentration is going to be decreased by half. The next one, assuming 100% bioavailability, and again, either they're going to tell you the drug is 100% bioavailable, or they're going to say the drug is given IV, and if it's an IV drug, you're assuming it's 100% bioavailability, because bioavailability takes into account getting the drug from your gut into your bloodstream. But the question is, what oral dose of drug X would be necessary to maintain the new target level? So we're looking for maintenance dose here. So maintenance dose is equal to the concentration at steady state times the clearance. So here, our concentration at steady state is 10. Clearance was given in the question stem, 2 liters per hour. So here we have 20 milligrams per hour. The next one, if a patient has a kidney problem and the clearance is reduced to 1 liter per hour, but the volume of distribution is unchanged, what effect will this have on the loading dose and maintenance dose? So this one, the loading dose is based upon the volume of distribution. And we said the volume of distribution is unchanged. So with this, the loading dose is not going to change. The maintenance dose will be decreased because of the reduced clearance. So you have to decrease the maintenance dose and not change the loading dose. All right, now one other thing, going back to those 4 equations, this is your step 1 hint for the day. When you step into your step 1 exam, you're going to go to your testing center, and at that testing center you're going to show your ID, you're going to show your testing center card, you're going to have to sign in, and they're going to give you a marker board. And usually the marker board just consists of 2 laminated sheets of paper and a dry erase pen. And you take that into the testing center. And you sit down at your computer, and when you sit down at your computer, your test has not started. Your test does not start until you log into your computer and start your test. So there's a period of time between when you sit down and when you start your test. And that period of time is, for most students, 30 seconds or something. But I think that's a great idea to spend about maybe 5 minutes after you sat down, when you have those marker boards, and just regurgitate some of the things that are going to help you process information more quickly on your test. And one of those pieces of information are these 4 equations. All right? If you can put these 4 equations on your marker board before you start the test, then you don't have to think about what those equations are during your test. When you encounter one of those questions, and you will have questions, this is 4 or 5-star topic, then all you have to do is just plug and go. You have the equations right there in front of you, you plug in the numbers and you go. You don't have to use the mental energy to remember what those equations are during the test. So I think it's a good idea to get that out of the way before the test. So you can put information on your marker board, on your laminated pieces of paper before your test. Now, but there is one caveat here, all right? You can't spend 30 minutes writing information on your marker board before your test. That's considered, unusual behavior or aberrant behavior or whatever it is they call it. But 5 minutes is acceptable. 10 minutes, probably pushing it. Any more than 10 minutes, you probably get called out on it. So it's not cheating to take 5 minutes and do that. This is information that's in your head. They're testing your knowledge. You're just putting the knowledge on the piece of paper before your test. All right, but you will get called out if you sit down too long and you're working on that for too long. So only about 5 minutes. So figure out which equations and which pieces of information you want to spend 5 minutes putting on that marker board before your test. All right, looking at the bottom, page 228 of First Aid, pharmacokinetics, half-life. Let's talk a little bit more about half-life. So like it says, it's the time required to change the amount of drug in the body by a half during the elimination or during a constant infusion. A drug infused at a constant rate reaches about 94% of steady state after 4 half-lives. That's a number you want to know. All right, so 94% after 4 half-lives. So that's given drug infusion. So if you're infusing a drug constantly, it's going to hit 94% at 4 half-lives of the drug, but it's also going to be eliminated the same way. So if you let a patient sit for 4 half-lives, 94% will be eliminated by that time also. So it works both ways. So I would know these numbers at the bottom of page 228. So at 1 half-life, obviously you have 50% of the drug left, or you've achieved 50% of your target concentration. At 2 half-lives, you take another 25%, so now you're at 75%. So it's 50 of 50, 75. 3 half-lives, you're at 87.5. At 4 half-lives, you're at 94%. So those are numbers you definitely want to know. All right, so know what Km and Vmax are. Know your 4 equations, and know about half-life and memorize those numbers for half-life. All right, so I've just given you like 5 questions for step 1. Very high yield day today, guys. All right, page 229, dosage calculations. Very important to know, but we just covered this, loading dose and maintenance dose. They factor in F here in the equation, which is bioavailability. Again, that takes into account oral administration of the drug. The thing with F for bioavailability is I've never heard of a student having a question that asks you to take into account bioavailability. So they're either going to say it's 100% bioavailable in oral form, which it never is, but they'll say that it is on your question stem, or they'll say that the drug is given IV. All right, so it'll make it a little bit less cumbersome for you to memorize those equations. All right, let's move on to drug elimination on page 229. So we touched on this earlier when we were talking about enzyme kinetics. There's zero-order elimination and there's first-order elimination. We said that zero-order elimination appears as though the enzymes are saturated. It doesn't matter how much substrate there is, doesn't matter what the plasma concentration of the substance is. The enzymes available to eliminate the drug can only work so fast. All right, so it's basically saturation kinetics. No matter how much drug is in the system, it can only be eliminated at a particular rate. In this example they have here, it's 2.5 units per hour. So that's zero-order elimination. Make sure you can identify that term. So what What else do you need to know about zero order? Like it says, CP decreases linearly with time. What is CP? It's a plasma concentration, all right? So plasma concentration decreases linearly with time. Examples of drug, I would know these examples. Phenytoin, ethanol, aspirin are all zero order elimination. Like it says on the margin, PEA is a way that you can a mnemonic you can use. Like a P is round, shaped like a zero, in zero order, so that can help you. First order elimination. Like it says there, the rate of elimination is proportional to the drug concentration. And the plasma concentration, the CP, decreases exponentially with time. So the more drug is in the system, the higher the plasma concentration of the substance, the more rapidly it's going to be eliminated. So you can see that in the graph on the right. 5 units per hour is eliminated, then 2.5, and then 1.25. So more drug equals faster elimination with first order elimination. All right, that's basically it. Just need to know what those terms are. Moving on to urine pH and drug elimination. This is also important to know. First thing you need to know here, like it says there, is ionized species get trapped. All right, why is that the case? Ions don't cross through a plasma membrane very easily, right? So ionized species gets trapped. Now the other part of that is uncharged molecules that do not have a charge, can go through plasma membranes. All right. So those are the two components you need to know here. So we're talking about weak acids and weak bases. I don't think they do a very good job explaining what's going on here. So I've explained it a little bit better in your handouts. So let's look at your handouts, page 2, underneath that pharmacokinetics section. So weak acids. So weak acids dissociate into hydrogen ions and an anion. And weak bases have a positive charge, and they get dissociated into a hydrogen ion and an uncharged base. All right, so we're just going through some of the basic stuff here before we can talk about the principles of drug elimination. So one of the other basic pieces of information you need to know is pKa. What is pKa? And that's that first bullet there. It's the acid dissociation constant. So pKa is the pH at which the amount of the non-protonated form equals the amount of the protonated form of the drug. So where these two sides of this equation are balanced, where the amount of acidic drug is equal to the amount of anions for weak acids, where the amount of the basic drug is equal to the number of uncharged base components in the weak bases. So that's the pKa, the acid dissociation constant. All right, so now let's move on to the principles here. The second bullet. If the pH is low in an acidic environment, low pH, acidic environment, and more importantly, the pH is less than the pKa for that substance, there will be more of the protonated form. This makes sense. There's more acid around, more protons around. There's going to be more of the protonated form. So what's going to happen here is the basic drugs are going to get trapped because the basic drugs are charged. The acidic drugs, when they're protonated, are not charged. So the basic drugs get trapped. Basic drugs cannot cross through the plasma membrane anymore. Acidic drugs can in acidic environments. If the pH is high, as in a basic environment, and more importantly, higher than the pKa, then there will be more of the non-protonated form. So for weak acids, they will have a charge. Your weak bases will not have a charge. So acidic drugs, the charged ones, are going to get trapped here. So why is that important? In order to treat an acidic drug overdose, for example, salicylates like aspirin, you're going to use sodium bicarb. All right, so treating acids, you use sodium bicarb. Now, why do you do that? Like it says there, you're going to trap the acidic drug in the basic urine. So you put sodium bicarb so the sodium bicarb can be renally excreted, and the substance will then not be reabsorbed in the tubules. All right, so that's how you get rid of acidic drugs. You trap it in the urine by giving a base like sodium bicarb that's going to go into the urine and trap the acidic drug there. It's a bit confusing because you might be thinking, you give bicarb and you're going to trap, you're going to have bicarb in the serum, and that's going to trap the acidic drug in the serum. Well, you're going to concentrate the bicarb in the urine, and that's going to trap the drug in the urine, and that's the more important principle here. And the last one, treat basic drug overdose like amphetamines with ammonium chloride. So ammonium chloride traps basic drugs in acidic urine. So when you're talking about eliminating drugs and giving bases to eliminate acids, giving acids to eliminate bases. The important principle is that's happening in the urine, right? All right, so that's pretty much it for urine pH and drug elimination. Moving on page 229, phase 1 versus phase 2 metabolism. So phase 1 is reduction, oxidation, hydrolysis. What does it do? You have slightly polar, water-soluble metabolites that often are still active. Phase 2 is acylation, glucuronidation, sulfation. You have very polar, inactive metabolites that can be more easily renally excreted. All right, now the thing going on, of course, where is this happening? This is happening in the liver, happening in the kidneys, but primarily the liver. It's not you go through phase 1 and then you go through phase 2. All right, so it's not a stepwise process. These are just categorizations of different things that can happen in the liver and different ways that substances can be metabolized in the liver. So sometimes phase 1 will inactivate a substance. Sometimes phase 1 will actually activate a substance and make it more toxic to the system. Same thing for phase 2. Sometimes phase 2 is going to inactivate, sometimes it will activate. But in general, phase 2 makes things more easily renally excreted. Substances might go through phase 1 on the first pass through the liver and then go through phase 2 on the second pass. Or they might go through phase 2 on the first pass through the liver and then through phase 1 on the second pass. They might go through both phases on a particular pass through the liver. They might only go through one phase. Depends on what the substrate is. All right, so the other key components here in understanding phase 1 versus phase 2 is what's in the margin. All right, and this is a huge hint for you guys. These little points in the margin of first aid are some of the highest yield points you're going to find in first aid. So that phase 1 contains cytochrome P450 is important to know. That phase 2, you have conjugation, and then that third thing, that geriatric patients lose phase 1 first. Hugely high yield, guys, all right? So it's a common mistake of students as they're going through first aid to think that the meat and potatoes is in the main part and that the margin points are less important. The margin points, I mean, think about it. Why did they decide to put those random pieces of information in there? The reason why those random pieces of information are there in the margin is because they're important. That's the only reason why you would put a random piece of information in the margin. All right, moving on, efficacy versus potency. So we touched on efficacy and potency when we were talking about Vmax and Km. So efficacy is the maximal effect a drug can produce. So we're talking about Km or Vmax here. Efficacy is Vmax. And then potency is the amount of drug needed for a given effect. It's the amount of the concentration of substrate needed to get to a certain point. So this is Km, right? So Km determines potency, Vmax determines efficacy. Very important concept to know. And let's go and look at this slide because you need to interpret these concepts based on graphical representation. So looking at this slide here, comparing efficacy and potency versus when you're looking at maybe competitive inhibition, non-competitive inhibition by certain substrates. Let's just specifically look at the lines, all right? So comparing line A to line B, what can you say about efficacy and potency? So it definitely has a lower Vmax, right? So because line B has a lower Vmax, what that means is it has a lower efficacy. So A has a higher efficacy than B, a greater maximal response, a higher Vmax. And what can we say about C compared to A? Well, C, you're requiring a higher dose of a substance to get to a certain maximum response, or even half of Vmax. So as that dose is increasing, your Km is increasing. So as you increase your Km, you decrease potency. So what you can say here is that substance A is more potent than substance C. So A has a higher potency than substance C. You need a lower dose, a lower substrate concentration to elicit that maximum response. What can we say about the efficacy of A compared to the efficacy of C? The Vmax is not changing here, right? So the efficacy of A compared to the efficacy of substance C is no different. So you're changing potency with C, but not changing efficacy. So again, basic concepts, very important to know. Let's go to the next page, 230. Talk more about pharmacodynamics. This also 4-star topic, possibly 5-star topic. You need to know how to interpret these graphs of pharmacodynamics. And we touched on this earlier because this also goes back to Km and Vmax is what we're talking about, and competitive versus non-competitive inhibition. So let's start with this topic by looking at this. And we mentioned this earlier, that competitive inhibitors, like you see on this slide, are competing for the same substrate or the same substrate site on the enzyme, and then non-competitive inhibitors bind to a site different to where the substrate binds. And by binding to that site, it induces a conformational change in the enzyme, which thereby inhibits the binding of the substrate to that active site. Now, one other thing to know about non-competitive inhibitors is they're also commonly referred to as irreversible inhibitors. So non-competitive inhibition is irreversible inhibition. So you're going to see those two terms used interchangeably. Non-competitive is the same thing as irreversible. So let's look at these two graphs on page 230, graph A and graph B. So what you see on these two graphs is you have an agonist, and then you put into the system a competitive antagonist. So a competitive inhibitor, competitive antagonist. And what does that do? You're shifting the curve to the right. You need a higher dose to achieve a certain response. So you're increasing Km. And is that going to change your efficacy, or is that changing your potency? You're increasing Km, it's decreasing your potency. All right, know that. Looking at the next graph, graph B, what you see here is you have an agonist, and then you have an irreversible antagonist. What's the other name for an irreversible antagonist? A non-competitive antagonist. So you see here, this is decreasing your Vmax. Is Km different? No, the Km for both is 1.0. So you're not changing Km. The potency is not changed. You're decreasing your Vmax, so you're changing your efficacy. You're decreasing the efficacy here. All right, basic stuff, but you got to know it. Let's look at graph C here towards the middle or bottom of the page. So what we have here is we're not talking about a competitive antagonist. We're not talking about a non-competitive antagonist. We're talking about a partial agonist here. So a substance that kind of works like a full agonist, but not quite. So what do you get with a partial agonist? How does it compare to a full agonist? Well, graphically, what they've shown you here is that you have you're decreasing your Vmax, which decreases the efficacy. But what they're also showing you here is you're shifting the curve to the left on this particular. So here you've increased, you're decreasing your Km, which is increasing your potency. Now, I don't really like the way that this is written because I think it's confusing. There's a caveat here. Look at that very last sentence in this section. It says a partial agonist may be more potent, as in the figure, less potent, or equally potent. Potency is an independent factor. So the main thing to know here is that a partial agonist is always going to decrease your Vmax and change your efficacy. So a partial agonist will not be as efficacious as a full agonist because the Vmax will always be lowered. Potency is a different variable. And so what I've done is on this slide, I've put two different partial agonists. I've taken what they've done in first aid and added to it. So what I've done here is made a separate line. So you have partial agonist A and partial agonist B. So with both of these, you're decreasing your Vmax, decreasing your efficacy. But with partial agonist A, you're increasing, you're lowering your Km, increasing your potency. Partial agonist B, you have a higher Km, so you have a decreased potency. So this is just illustrating that point, that potency is an independent variable, but in both cases, partial agonists lower the Vmax and decrease your efficacy. All right, let's move on to the last topic in this pharmacodynamics section, which is therapeutic index. So therapeutic index at the bottom of page 230 is a measurement of drug safety. You see there's this LD50 and ED50. It defines LD50 as a median toxic dose, and then ED50 as a median effective dose. Now, to be more specific and make it more memorable for you, let me tell you what is ED50 and LD50. LD50 is the lethal dose. That's where the LD comes from. It's the lethal dose, the dose that's lethal to 50% of the population. So that's where that 50 comes from. It's a lethal dose to 50% of the population. And the ED50 is the effective dose to 50% of the population. So two things here. Number one, we're talking about 50% of the population. So the therapeutic index from person to person is going to be different, right? Because this is just an average. We're looking at the median. The second thing here is to know how changing your ED50 and LD50, how that changes your therapeutic index. So you can have a high therapeutic index and a low therapeutic index. Which is preferred? Well, if you look there in the margin, it says safer drugs have a higher TI value. So a high therapeutic index means the drug is safer. Let's think about that. You can look at the numerator. If your LD50 is going up, it means you require a higher dose of the medication to hit that lethal dose. That makes it safer, right? Alternatively, you can look at the denominator and look at the effective dose. A very, very small amount of the medication is going to be effective, and that's going to increase your therapeutic index. So it's good to have a high therapeutic index, and you can have a high therapeutic index when the lethal dose is very, very high and or the effective dose is very, very low. So what are some drugs that have a low therapeutic index, where it doesn't take much more additional medication to make it lethal? Well, these drugs are drugs that we tend to monitor, or that we have to monitor on a very regular basis. So a lot of your seizure drugs like phenobarbital, drugs like lithium, digoxin, and Coumadin, or warfarin. So these are all drugs that have a low therapeutic index. So just think about the drugs that you need to monitor very regularly. Lithium, digoxin, Coumadin, phenobarbital. All right, so that is it for therapeutic index. Let's move on. There's one last thing I want to talk about with pharmacodynamics. It's not in this section. It's actually towards the beginning of your book. And it's on page 52 of your book. So this is clinical trials. It's on page 52, clinical trials. So what is a clinical trial? Experimental study involving humans compares therapeutic benefits of 2 or more treatments or of treatment versus placebo. It's a high-quality study when randomized, controlled, and double-blinded. All right? So that's how you factor out errors. As you make it randomized, you make it controlled, and double-blinded. So the person administering the study and the person in the study, neither of them know which patients are taking the placebo and which patients are taking the experimental medication. But let's go through the phases. That's the main thing I wanted to talk about here. So there's different phases of a clinical trial. There's phase 1, like it says there, you're using healthy volunteers. Purpose, assess safety, toxicity, and pharmacokinetics. All right, so I'm going to give you 3 questions to know with these different phases. It'll make it a lot easier for you. Phase 1, is it safe? So phase 1 determines, is the drug safe, primarily. Phase 2, does it work? All right, so phase 2, does it work? So you look at patients with the disease, and like it says there in the margin, the purpose is to assess treatment efficacy, optimal dosing, and adverse effects. So you're taking it a step further, give it to patients with the disease. Who goes through phase 1 trials? College students, right? So this is college student volunteers primarily that are voluntarily taking the drug. Young, healthy individuals. Moving on, phase 3, what's the question here? Does it work better? So phase 3 trials are the trials that you commonly see like in the New England Journal and other journals where you're comparing the drug to a drug that already exists on the market. The question, does it work better? Does it work better than what's out there? Look at the purpose there on the margin. It says compares the new treatment to the current standard of care. There's one more phase I want to throw in there, which is phase 4. So what is phase 4? It's post-market surveillance. So all you have to do to get through the clinical trials is to go through the 3 phases. It's released onto the market, and then you have phase 4, post-market surveillance. How long does it take to go through all these phases? It varies from drug to drug, but in general, it could be anywhere from 5 to 10 years to go through all these different phases. All right, and then one more thing I want to talk about with pharmacodynamics is actually not that important for step 1, but I think it's a topic that you need to be introduced to going into your 3rd year of medical school, going into your clinical rotations, which is your FDA drug classes. All right, so don't write this down, just a brief overview of this so that you've seen it before you go into your clinical rotations. So there's 5 different FDA drug classes. There's class 1, and as you go from class 1 to class 5, the abuse potential goes down. And how tightly regulated the drug is goes down. So class 1 are the most highly regulated drugs. They're actually illegal. So the examples here include heroin and LSD. There's no medical use for class 1 drugs. They're simply illegal drugs. Class 2 also has a very high abuse potential. So we used to have to fill out what's called a triplicate form. And a triplicate form is a form that you fill out the prescription, and then there's 2 carbon copies underneath it. So when you write the prescription, you're actually writing 3 of the same prescription, and that way there's 3 records of the prescription. And so that's one way to control this. And you would keep a record, and the patient would be given one to take to the pharmacy. So that's a triplicate form. Nowadays, we don't have triplicate forms. What we have is, I mean, they might be called triplicate forms, but they're on no copy paper. It's on paper where if you copy it, it shows copy, copy, copy on it. So that's the thing. We don't want the patient to copy the prescription and then use it multiple times. But morphine is an example of that. Class 3, moderate abuse potential. Drugs like hydrocodone, Vicodin, right, is what we're talking about here. Class 4 has very low abuse potential. Metoprolol would be an example here. Your beta blockers, these are not drugs of abuse at all. And then class 5, the abuse potential is so low that these drugs can be over the counter. All right, so that is definitely it for pharmacodynamics. Let's move on to autonomic pharmacology. Huge topic, guys. Autonomic pharmacology, very, very high yield. So we're going to start our discussion of autonomic pharmacology on page 234 with the cholinomimetic agents. Before we go into those, let me just briefly introduce autonomic pharmacology to you guys. So autonomic pharm is huge for this test. You need to know every single autonomic drug, which receptors it's working at, and what that drug is used for. So it's a kind of a daunting task because autonomic pharmacology is one of those topics that medical students like to back burner and try to avoid because it can be really confusing. So I'm going to make it pretty easy for you guys. So let me introduce it this way. We like to think of autonomic pharmacology as either fight or flight, which is your sympathetic, and rest and digest, which is parasympathetic. But when you're talking about drugs, it gets more complicated than that because you can have parasympathetic activation, which would be rest and digest, but then you can also have parasympathetic inactivation. Okay, so the opposite of parasympathetic is not sympathetic. The opposite of parasympathetic is anti-parasympathetic in the drug world. So you either have rest and digest or anti-rest and digest. And then when you're looking at your sympathetic drugs, you can have sympathetic activation of specific receptors, and then you can have sympathetic inhibition of specific receptors. So in the sympathetic world, not only are you dealing with activation and inhibition, you're dealing with activation and inhibition of very specific receptors. So it's even more complicated for sympathetic drugs. But I'm going to make it very easy for you guys. So let's start with the parasympathetic. Actually, let's start with just a brief overview of what the sympathetic and parasympathetic drugs do in general. So look at page 3 of your handout, number 1. How did the sympathetic and parasympathetic nervous systems affect the following structures? So take a look at that, answer those real quick, and then we'll go through those answers together. All right, so starting at the heart. So sympathetic is of course going to increase your heart rate and contractility. Sympathetic, we're talking about epinephrine, norepinephrine in general. Parasympathetic, which nerve carries the most parasympathetic information to the heart? Is your vagus nerve, right? So parasympathetics are going to decrease your heart rates and decrease contractility. In your eyes, parasympathetic causes mydriasis, which is dilation, and parasympathetic causes miosis, which is contraction of the iris. If you have a hard time remembering what the terms mydriasis and meiosis mean, if you confuse the two, there's 2 ways you can remember this. Number 1, mydriasis has a D in the word for dilation of the pupil. But the way that's easiest for me, because I'm kind of unusual, is mydriasis is a much longer word. So I think about, if you had to fit that word inside of a pupil, meiosis would fit into a much smaller pupil. Mydriasis, longer word, would require a much larger pupil. All right, moving on. Salivary glands. With sympathetic activation, you have very viscous secretion, which is why lecturers have to drink water during the lecture because they're nervous. They have more sympathetic activation. They have sort of a tackiness in their mouth that needs to be diluted. Parasympathetic causes a watery secretion. Makes sense. You want to dilute that so that you can digest food more easily. Bronchial or smooth muscle. Your sympathetics are going to cause relaxation, which is why we give epinephrine for anaphylactic shock. And they're going to cause, parasympathetics cause contraction, which is why when we're treating COPD or asthma, we give anti-parasympathetics. In your bladder, sympathetics prevent urination. Parasympathetics are going to cause urination. The male genital urinary tract, this is your point and shoot mnemonic. P for point, P for parasympathetic. So parasympathetics cause erection, and then S for shoot. And S for sympathetic, so you have ejaculation by your sympathetic. So in order to achieve an erection and ejaculation, there's a balance between sympathetic and parasympathetic. In the GI tract, your sympathetics are going to decrease digestion because you don't want to be digesting food when you're running from a lion. So with that, you have relaxation of smooth muscles in the walls of your gut. You have a contraction of sphincters so that food doesn't pass from your stomach to your duodenum. It doesn't pass from one compartment to the next. You're going to have decreased secretion and motility. So basically, you're going to, in some ways, induce an ileus here. Your parasympathetics are going to increase digestion. So you're going to have contraction of smooth muscles for peristalsis. You're going to have relaxation of sphincters. You're going to have increased secretion and motility. So you use parasympathetic agents to treat ileus. All right, so let's talk about these drugs. I guess first of all, let's talk about what happens when you give too much of a parasympathetic drug. So we have all these drugs that increase parasympathetic activity. If you give too much of it, you overdose. What do you get? So this is number 2 on your handout. What are the symptoms of excess parasympathetic activity? The mnemonic here is dumbbells, and this mnemonic can be seen at the bottom of page 234 in the margin. D-U-M-B-B-E-L-S-S, dumbbells, for diarrhea, urination, meiosis, bronchospasm, bradycardia, excitation of skeletal muscle and the CNS, lacrimation, sweating, salivation, and abdominal cramping. All right, so dumbbells is a mnemonic you can use. The way I remember it is parasympathetic drugs just make you leaky. Anywhere that you can have fluids or water come out of your body, parasympathetic drugs will make it come out of your body. So you have diarrhea, you have urination, you have increased secretion in your bronchial tree and bronchospasm, you have lacrimation, tearing, you have sweating, you have salivation. So you just get very leaky with parasympathetic activity. And then let's look at number 3 on your handout, page 3. What drugs can cause excess parasympathetic activity? Basically everything on page 234. So all those drugs on page 234 in excess can cause excess parasympathetic activity. So let's talk about these drugs. Starting with your cholinomimetic agents. So cholinergic agents, agents that stimulate the parasympathetic acetylcholine receptor are called cholinomimetic agents. Specifically, which acetylcholine receptor are we talking about? There's 2 different flavors of acetylcholine receptors. There's nicotinic acetylcholine receptors, and there's muscarinic acetylcholine receptors. We're talking about the muscarinic receptors here. So there's 2 different ways that you can stimulate these receptors. Number 1, by using a direct agonist. And these direct agonists bind directly to the receptor. That's easy enough. Now, the way that your body gets rid of acetylcholine that's in the receptor is it has an enzyme in the synapse of your acetylcholine receptors. And that enzyme degrades acetylcholine so it doesn't stick around indefinitely. And that enzyme is acetylcholinesterase. So another way that you can cause excess cholinergic activity is to inhibit that acetylcholinesterase. And if you inhibit that acetylcholinesterase, then acetylcholine that's endogenous to your body does not get degraded as rapidly, and so acetylcholine sticks around longer. So these drugs are called your indirect agonists, or anti-cholinesterases, or anti-acetylcholinesterases. They're indirect. They don't directly bind to the receptor, but they allow acetylcholine that's endogenous to stick around longer. But let's talk about your direct agonists first. You guys need to know all these drugs. One thing that's easy about most of the direct agonists is they have CHOL in the name, chol for cholinergic agonists. So bethanechol, carbachol, methacholine. So starting with bethanechol, it's used for post-op and neurogenic ileus and urinary retention. Carbachol is used for glaucoma, for pupillary contraction and release of intraocular pressure. So it's used for glaucoma, basically. We have glaucoma, you have elevated intraocular pressure. Pilocarpine is used for the same reason. Pilocarpine is actually very, very commonly used for glaucomic emergencies. So carbachol, pilocarpine, think of those 2 as glaucoma drugs. Pilocarpine, is, like it says, there's also a stimulator of sweat, tears, saliva. Again, these drugs make you leaky. Methacholine is used as a challenge test for the diagnosis of asthma. So I said your anticholinergic drugs are used to relieve asthma. Well, this is a cholinergic drug. It's going to cause bronchoconstriction. Like it says there, it stimulates muscarinic receptors in the airway when inhaled. So this is not a drug that's used for anything other than for diagnostic purposes, never for treatment purposes. All right, let's move on to your indirect agonists. One huge hint for your indirect agonists is a lot of them have stigmine. If you see stigmine in a drug name, it's an indirect cholinomimetic. All right, so neostigmine is your prototype. So it also is used for post-op and neurogenic ileus, like we saw bethanechol being used for. Also used for urinary retention, can be used to treat myasthenia gravis. We'll talk about myasthenia gravis in a second, but what is it? It's where you have antibodies to the acetylcholine receptor. So in those cases, you're going to need acetylcholine to stick around longer to work. So these agents help that. Also, reversal of neuromuscular junction blockade. So if you have a patient that you've put under and you've paralyzed for a procedure, maybe you've used succinylcholine to paralyze a patient. Maybe you've used one of your curium or curonium drugs like rocuronium, vecuronium. Those are all depolarizing, or those are all paralyzing agents. If those are around and you need to reverse that, neostigmine is your drug of choice. That's what you use. So anesthesiologists can use neostigmine. Moving on to the next one, pyridostigmine. So pyridostigmine gets rid of myasthenia gravis. Use that mnemonic, RID. Pyridostigmine gets rid of myasthenia gravis. While we're here, let's go ahead and talk about myasthenia gravis. So myasthenia gravis, look on page 3 of your handout, number 5, myasthenia gravis. And this is also in your book, in a different section of your book. So we'll touch on it again later, but I think this is a good place to talk about myasthenia gravis. So what is it? Like I said, it's antibodies to the acetylcholine receptor. The second bullet in your handout, most common board question, presentation, is ptosis, drooping of the eyelid, or diplopia, double vision, that worsens as the day progresses. So worsens throughout the day. Ptosis or diplopia, drooping of the eyelid, or double vision that worsens throughout the day. How do we diagnose this? Is a tinsilin test. What is tinsilin? Tinsilin is the brand name for edrophonium. So what is edrophonium? Let's look back at page 234. It's right under pyridostigmine. It's used for the diagnosis of myasthenia gravis. It's extremely short-acting. The duration of edrophonium is less than 30 minutes. So you give edrophonium to a patient to see if their symptoms improve. If their symptoms improve with edrophonium, most likely going to be myasthenia gravis. It's how you diagnose it. The other thing that's important and unusual about myasthenia gravis is there's this thymus pathology that often is associated with myasthenia gravis. Not always, but often. Like it says in your handout, 50% of the time, these patients are going to have thymic hyperplasia. So thymic hyperplasia, 50% of the time. 20% of the time, they have thymic atrophy. And 15% of the time, they have thymoma. So a tumor of the thymus, thymoma. The next bullet, what is a myasthenic crisis? It's a rapidly progressing weakness, especially in respiratory muscles. This is the most feared complication of myasthenia gravis, is that your diaphragm can't contract anymore. How do we treat it? So we've mentioned one category of drugs, your acetylcholinesterase inhibitors, which are your indirect cholinergic agonists. So your acetylcholinesterase inhibitors like neostigmine, like pyridostigmine, gets rid of myasthenia gravis. What else can you use? The second one is corticosteroids. This is an autoimmune disease. Knock down the immune system with corticosteroids. What's your third treatment choice? Is thymectomy. Taking out the thymus is going to get rid of the thymus pathology, but also often is going to be curative for myasthenia gravis. And a fourth option is plasmapheresis. Plasmapheresis. So taking out the patient's plasma. What are you doing here? With plasmapheresis, you're pulling out the patient's plasma, getting rid of antibodies that are in the plasma, and then putting back the plasma that remains. So if you get rid of the antibodies to the acetylcholine receptor, then you're not going to have as much disease, right? So that's what's going on with plasmapheresis. So 4 options: acetylcholinesterase inhibitors, corticosteroids, thymectomy, and plasmapheresis for myasthenia gravis. All right, moving on with your other cholinergic agents. Physostigmine. So physostigmine is used for glaucoma, like we saw carbachol and pilocarpine. Ecothiophyte is also used for glaucoma, but one very important thing I want you guys to know about physostigmine is that it fixes atropine overdose. So and you can spell fix, P-H-Y-X, fix. Physostigmine fixes atropine overdose is a mnemonic here. Very, very important to know. Make sure you know that. All right, so there are additional anticholinesterase drugs that are not in first aid. So what are those drugs? So go ahead and take a look at handout page 3, number 4, where it says Alzheimer's acetylcholinesterases. The fundamental problem with Alzheimer's is you have decreased acetylcholine in the brain. So these drugs are going to help raise acetylcholine levels, so it makes sense. Alzheimer's is a problem with low acetylcholine, so we give anticholinesterases. And there's 3 that we have in your handout. Donepezil, which you might know better as Aricept, galantamine, and rivastigmine. So those are ones that are worth knowing as well. All right, what other drugs, what other substances stimulate the cholinergic system, stimulate the parasympathetic system? Look in the margin on page 234 under that cholinesterase inhibitor poisoning. So there's other substances that inhibit this acetylcholinesterase enzyme, and you can be poisoned with these substances. And that substance, like it says in the margin, is parathion and other organophosphates. All right, what is parathion? It's an insecticide. So use these 3 terms interchangeably. Parathion, insecticide, organophosphate. All right, parathion is an insecticide that is an organophosphate. All those substances are cholinesterase inhibitors. In excess will cause you to be very leaky. So what are the symptoms of insecticide poisoning? Is leakiness. You're tearing up, you're salivating, diarrhea, urination. If you see a patient coming in with those symptoms and bronchospasm, having a hard time breathing, the first thing that should come to your mind is insecticide poisoning. And typically for step 1, there'll be a history of the patient being a gardener or a history of the patient being a farmer or something like that. And then one other side note here with organophosphate poisoning or insecticide poisoning, this is more step 2, but let me just throw it out there, is when you are evaluating this patient, number 1, they need to be rinsed very, very thoroughly because this stuff is on their skin and that's how they're getting poisoned. So this needs to be diluted as early as possible and as much as possible. But number 2, when you're examining the patient, you can get it on your skin from the patient's clothes and the patient's skin. So you always need to make sure that you are gowned and gloved when you're treating a patient for organophosphate poisoning. How do we treat organophosphate poisoning? Rinse the patient, and then also it says here the antidote is atropine, which is a muscarinic antagonist, plus pralidoxime. The pralidoxime, like it says, is a chemical antagonist used to regenerate active cholinesterase. So pralidoxime regenerates that enzyme that was inhibited. And it's very important for pralidoxime to give it as soon as possible. The earlier you give it, the better the outcome is going to be. So pralidoxime is going to undo what's been done, but to reverse the symptoms, you use atropine. All right, but the 2 are given together in the treatment here. So this is the answer to number 6 on page 3 of your handout. What drug regenerates acetylcholinesterases after organophosphate poisoning? Pralidoxime. Make sure you know it. All right, so that is it for parasympathetic stimulation, the drugs that stimulate the parasympathetic nervous system. So make sure you know all of those drugs as parasympathetic stimulators, as cholinergic agents. So just sort of box that off in your brain, put all those drugs in that box. Now we're going to talk about the reverse, parasympathetic inhibition. Now we're not getting more leaky, we're getting less leaky. We're retaining fluid, we're causing ileus. We are decreasing secretions in general by inhibiting the cholinergic receptor. The muscarinic receptor in particular is what we're talking about. Remember I said there's 2 acetylcholine receptors, nicotinic and muscarinic. Here we're inhibiting the muscarinic receptors. So we're looking at page 235. Now your prototype drug is atropine. Prototype drug atropine. Look at page 4 of your handout, question number 1. What are the symptoms of inhibiting parasympathetic activity? The answer to this question is under the section on atropine on page 235. Look in the margin, it says side effects, hot as a hair, dry as a bone, red as a beet, blind as a bat, mad as a hatter, and another one I want you to throw in there is bloated as a toad. Bloated as a toad. So what does all that mean? Look just to the left of that where it says toxicity. It says increased body temperature, hot as a hair. It also says dry mouth, dry as a bone, dry, flushed skin. If you have dry skin, it's also flushed. That's your red as a beet, flushing. Cycloplegia. What is cycloplegia? What does plegia mean? Plegia is paralysis. You know hemiplegia. You know paraplegia. This is cycloplegia. So what does cyclo mean? This is paralysis of the muscles of the ciliary body in your eye. Paralysis of the muscles of the ciliary body is cycloplegia. Paralysis of the muscles of the ciliary body. So because of that, you have relaxation and loss of accommodation. And with that loss of accommodation, you get blurry near vision. So cycloplegia, paralysis of the muscles of the ciliary body. This is not the eye movement muscles. This is the muscles that change the shape of the lens through the zonules. So you lose your ability to accommodate and your vision gets blurry because your lens is not appropriate. So atropine causes cycloplegia. Blind as a bat is what we're talking about here. Constipation goes back to the bloated as a toad that I had you add in there. And also another one that you need to write in here is urinary retention. Also bloated as a toad. Constipation, urinary retention, bloated as a toad. And then the last one it says is disorientation. And you can actually throw in there delirium is what we're talking about. Atropine and muscarinic antagonists can cause delirium, mad as a hatter. All right, so that's where those terms come from. So that's what atropine does in toxicity. How do we use atropine? It's a muscarinic antagonist. Look back at first aid. So for the eye, atropine is going to cause dilation and cycloplegia. So the dilation, sometimes we use atropine drops in the eye to cause pupillary dilation so we can do a very thorough retinal exam. The airway, atropine is going to decrease secretions. So atropine is very commonly used by anesthesiologists so that when a patient is intubated or when a patient is under conscious sedation, they don't have a whole lot of airway secretions that are choking them up. I mean, if you have a patient in conscious sedation, their reflexes are way, way down and they may not gag on saliva as well as they should. So by giving atropine to a patient under conscious sedation, decrease secretions, decrease gagging. In the stomach, atropine is going to decrease acid secretion. It's going to decrease gut motility, and it's going to decrease urgency in cystitis. So basically, you're more likely to have ileus, and you're more likely to have urinary retention with atropine. So what are some other drugs that are like atropine? And this is the answer to number 2 on page 4 of your handout. What drugs inhibit parasympathetic activity and what are their uses? So we just talked about atropine. What are some other drugs? The top of page 235 is where we're looking. Muscarinic antagonists. There's atropine, homotropine, and tropicamide. What 4 letters are common to those words? T-R-O-P. So trope is an indicator that you're dealing with a muscarinic antagonist. That's going to be helpful. So you have 3 drugs there. Looking further down, you have ipratropium as well. Benztropine. So trope tells you you're dealing with a muscarinic antagonist. Huge hint for you guys. So anyway, atropine, homotropine, and tropicamide are used in the eye to cause mydriasis, dilation, so you can do a retinal exam, but also side effects, you're going to have cycloplegia. Benztropine is used for Parkinson's disease. So going back to Alzheimer's, what's the problem with Alzheimer's? Is decreased acetylcholine. All right. What other disease has decreased acetylcholine? Is Huntington's disease. So with Huntington's disease and Alzheimer's disease, you have decreased acetylcholine. Parkinson's is just the opposite. Parkinson's, you have increased acetylcholine. So for Alzheimer's and Huntington's, you give a cholinergic drug. For Parkinson's, you give a muscarinic antagonist, like benztropine. Park my Benz is a mnemonic they give you in the margin that can help you. Scopolamine. What is scopolamine? It's a little patch you can put behind the patient's ear so it gets absorbed through the skin. It's given in 2 scenarios most commonly. It mentions one in your book, motion sickness. So if you're going to go deep sea fishing or if you get sick on a plane or something, you could put a scopolamine patch behind your ear so you don't have motion sickness and get nauseous. It's also commonly given, this little patch, in end-of-life care. So not that important for step 1, but clinically relevant. It's given for end-of-life care to help patients reduce nausea and vomiting, and also to decrease secretions in a patient that might be, coughing a lot. The next one is ipratropium. Ipratropium is used for asthma and COPD. You might know ipratropium better as Atrovent. So Atrovent is ipratropium. It's breathed in. Moving on, oxybutynin is used for genitourinary. Like it says there in the margin, reduce urgency and mild cystitis and to reduce bladder spasm. So there's two main types of urinary incontinence, right? There's stress incontinence and there's urge incontinence. Urge incontinence is where you have bladder spasms. So in cases of urge incontinence, you can use a drug like oxybutynin to reduce that. So the oxybutynin is used in patients with urge incontinence. What other drugs can be used in urge incontinence? Let's look page 4 of your handout, number 3. What anticholinergics are used in the treatment of urge-type urinary incontinence? There's oxybutynin, tolterodine, darphenocin, and solifenacin, and trospium. So these are drugs like, ditropan is one of these drugs. Detrol LA is another one of these drugs. But you don't need to know the brand names, you need to know the generic names. So those are the generic names for you on page 4. So those are worth knowing as well. All right, the next drug in your book is glycopyrrolate. So glycopyrrolate, it's under genitourinary, but glycopyrrolate is used commonly by anesthesiologists in the same way that we saw atropine being used by anesthesiologists. It's used to decrease airway secretions. So glycopyrrolate and atropine are used to decrease airway secretions, primarily. Moving on, methscopolamine is used for GI uses. What are we talking about here? Like it says in the margin, peptic ulcer treatment. What else is it going to do? It's going to decrease salivation, right? You're drying up with these drugs. Decrease salivation, decrease gut motility, decrease stomach acid. So that's why it's used for peptic ulcers. Now there list 2 other drugs here. Pyrenzapine, just cross out pyrenzapine because this is a drug that's not available in the U.S. Any drug that's not available in the U.S. will not be on your USMLE or COMLEX exams. But this third one, propantholine, think of it in the same terms as methscopolamine. Propantholine is used for GI uses as well. All right, so those are your muscarinic antagonists. All right, one last thing to know about your muscarinic antagonists is on page 4 of your handout, number 4. In what patient populations is atropine contraindicated? Definitely need to know this. Think about your side effects of these drugs. So populations where it's contraindicated, if you have glaucoma, all right? In patients with glaucoma, you do not want to dilate the eye. So you do not give a sympathomimetic like epinephrine, and you do not give a muscarinic antagonist like atropine. So glaucoma is a contraindication for atropine. BPH, or anytime you have urinary retention, prostatic hypertrophy. Those are cases, prostatic hyperplasia. So in cases of prostatic hyperplasia or in any scenario where you have urinary retention, you do not want to give a drug that's going to exacerbate the urinary retention. Another instance where this is contraindicated is GI obstruction. So this is going to slow down the gut. So any patient with an ileus, you don't give them these drugs. You don't give them atropine. Any patient with dementia, we said that the Mad as a Hatter, atropine can cause delirium. It's one of the most common causes of an elderly patient becoming delirious. Is a muscarinic antagonist. So if you have an elderly patient with, maybe it's an elderly woman and she has some incontinence, you try her on oxybutynin, she becomes delirious, that oxybutynin causes a delirium. So we do not give atropine to patients that are elderly. We do not give atropine to patients that have dementia. And we do not give atropine to patients that are delirious because it's going to throw them over the edge. Another scenario where you don't give atropine is in an infant with fever. An infant with fever because atropine can cause hyperthermia in infants. So glaucoma, BPH or urinary obstruction, GI obstructions or ileus, delirium, dementia, elderly, or in infants with fever, we do not give atropine or any of the other muscarinic antagonists. So definitely know those contraindications. So go ahead and look at page 5 of your handouts. There's a quick quiz over the parasympathetics. Complete this quick quiz to make sure that you really got parasympathetics down. And then after we go through the answers to this quiz, we'll go ahead and take a break. All right, so let's go ahead and go through this parasympathetic quiz. Number 1, what are the symptoms of excess parasympathetic activity? Dumbbells was your mnemonic here. You can also think of getting leaky everywhere. So you have diarrhea, urination, meiosis, bronchospasm, bradycardia, excitation of skeletal muscle, lacrimation, sweating, salivation, and abdominal cramping. And all those are in your book. Number 2, what are the symptoms of inhibiting parasympathetic activity? You become very dry, and you had hot as a hair. You increase your temperature. Dry as a beet, you have, or dry as a bone, you have decreased secretions, decreased salivation. Red as a beet is a peripheral vasodilation. Blind as a bat is a mydriasis and cycloplegia. Mad as a hatter is agitation, delirium. And bloated as a toad is constipation and urinary retention. Knowing these different drugs, again, very important for you guys, because you're going to have the question stem. It's going to have maybe side effects, or you need to, and then your answer choices will be the drugs. And it's it's about knowing which drug falls into which category. So you need to know which drugs fall into which category. So definitely very high yield to know all of these drugs, guys. Don't. This is just a huge topic, commonly overlooked by medical students. So make sure you know this autonomic form. Physostigmine is a anti-acetylcholinesterase. Pilocarpine is a direct muscarinic agonist. Ecothiophates is an anti-acetylcholinesterase. Oxybutynin is a muscarinic antagonist used for urge incontinence. Atropine is a muscarinic antagonist. Donepezil is an anti-acetylcholinesterase, which is an indirect agonist. Pralidoxime is a regenerator of acetylcholinesterase. So we saw that's used for organophosphate poisoning. Bethanacol is a cholinergic agonist. It's a direct agonist. Neostigmine is an anti-acetylcholinesterase. Darafenicin, ipratropium, tropicamide, benztropine, and scopolamine are all muscarinic antagonists. Edrophonium is an anti-acetylcholinesterase. Tolterodine is a muscarinic antagonist used for urge incontinence. Trospium is a muscarinic antagonist used for urge incontinence. Rivastigmine is an anti-acetylcholinesterase. Homotropine, trope, it's a muscarinic antagonist. Pyridostigmine, anti-acetylcholinesterase. And carbachol is a cholinergic agonist, a direct agonist. Number 4, a gardener presents with shortness of breath, salivation, meiosis, diarrhea. What caused this? This is, of course, organophosphate poisoning, insecticide poisoning. What's the mechanism of action? Is going to be your answer. So this is one of those next step questions, a two-step question. You need to know what caused it, and you need to know what the mechanism of action of the substance is that caused it. It's an inhibitor of acetylcholinesterase. These organophosphates inhibit acetylcholinesterase, causing excess cholinergic stimulation of the muscarinic receptors. Number 5, atropine is not effective in the reversal of organophosphate poisoning. What drug would best help this patient? So you can give pralidoxime. Pralidoxime, important to know, given very early. What's the brand name for pralidoxime? Not that it's important for this test, but it's 2-PAM. So maybe you've heard of 2-PAM. 2-PAM is pralidoxime. Regenerates acetylcholinesterase. Number 6, which of the following drugs would help improve FEV1 in a patient with COPD? Given a list of drugs, ipratropium. Number 7, 30-year-old schizophrenic male now has urinary retention due to his neuroleptic. So a lot of drugs out there, a lot of neuroleptics, and even drugs like Benadryl have a muscarinic antagonist effect. They're anti-muscarinic drugs. So we're going to see this muscarinic antagonist side effect throughout the course, particularly in the psychiatry section. Psychiatry section. So how do we treat this? Bethanacol. You give a cholinergic drug like bethanacol here. And the last one, in the dark, both eyes are dilated. So we have a slide of this for you guys to look at. In the dark, both eyes are dilated, and then you can see on the right-hand side in the light, the control pupil is miotic, while the pupil given drug X remains mydriatic. What is drug X? This is one of two drugs, either a sympathetic agonist, which we haven't discussed yet, but fight or flight response, epinephrine, norepinephrine is going to cause mydriasis. So it's either a sympathetic agonist or it's an anticholinergic drug. an antiparasympathetic drug, a muscarinic antagonist. Those are all terms that can be used interchangeably. Muscarinic antagonist, or this could be a sympathetic agonist. All right, let's go ahead and take a break here, and we'll come back and talk about some more autonomic pharmacology.